Good afternoon, everyone, and welcome to our webinar on neurogenic bowel management. This webinar is kindly going to be delivered by Michelle. I'll let Michelle do her own introductions and follows on from a webinar Michelle kindly delivered for us a few weeks back on bladder management. So thank you very much from us as a network in attending today's webinar. My name is Chris Ashton. I'm one of the facilitators and work alongside Gemma Smith, who you all know well. Just for awareness, obviously our websites are on the screen. We are recently merged a network and will merge into one larger website moving forward. And both websites are still actively open. Our Twitter handle is also there, so please give us a follow on Twitter and feel free to tweet about today's webinar. Just a few housekeeping. Please feel free to ask any questions in the chat on the panel, and hopefully we'll be able to answer these at the end. We will be recording today's event, and we'll ask you to fill an evaluation in when we email that out. Please feel free to keep an eye on future events on the website. And I have mentioned the YouTube channel. We do have all our previous webinars on the YouTube channel. We do have restricted access to some of them, so feel free to contact Lisa Chadwick at the bottom if you need access to any of these. So on that note, I'm going to hand over to Michelle. Thank you very much.
Hello, and thank you for joining me today. My name is Michelle Hogan-Tricks, and I am a neurogenic nurse specialist at Coloplast. I have been working in neuro and spine as a specialist nurse all of my career in central London at the National Hospital for Neurology and Neurosurgery, and just moved over to Coloplast around 7 months ago now. So today we are going to talk about neurogenic bowel, and if you listened into the neurogenic bladder talk a couple of weeks ago, some of this is going to be refresher and revision for you, but I always think that's great, just to embed everything in our brains. So I just wanted to put this first slide up just to say that bowel dysfunction in general actually is something that really distresses our patients, and patients that have bowel dysfunction, we know that it causes a significant emotional distress to many of the patients. Many spinal cord injury patients will say that their bowel dysfunction impacts on their quality of life and prevents them from doing things more than any other difficulty that they experience with their condition. I don't know if any of you are familiar with the cost of constipation report. This came out in 2020, and we're due an update very soon. It was done by Professor Anton Emmanuel and some various other specialists that he worked with on this. This is general data. It's not specifically for neurogenic bowel, but obviously it incorporates everybody with neurogenic bowel problems. But it's just to say, you know, that nearly 77,000 people a year are admitted to hospital with constipation. This data from the 2020 report was obviously the years before data. So we know that increased by 16% from the years prior to that, and we expect that the next report will show an increase again. Obviously we've had COVID in between, so that might skew the data slightly, but it is an increasing problem rather than a decreasing problem. You can see the cost there to the NHS, so NHS England, 168 million spent on, this is constipation alone, and this doesn't even, we think that that's an underestimate. We don't think that number doesn't really include all of your trips to your GP and back. And we know that constipation, if you suffer with constipation, that can cause chronic pain. It increases your likelihood of UTIs, in particular in our neurogenic patients. Obviously things like hemorrhoids, anal fissures, rectal prolapses. And about 40% of patients with constipation will state that they experience anxiety and depression because of their constipation, and around 50% of patients say that it severely impacts on their quality of life. But interestingly, the number is higher when they say it affects their performance at work or at school. It goes up to 69%. I just thought that was quite interesting. I would have expected that number to be around the same. Anyway, So now we're going to focus on neurogenic bowel. So what causes neurogenic bowel? Well, again, if you listened into the bladder talk, you'll see that this is the same list. So we think that pretty much everybody nearly that has a spinal cord injury is likely to be experiencing neurogenic bowel problems to some degree. In MS, it's up to 70%. It's reported that this number changes. We get it kind of at 50%, but then internationally they think the number's slightly higher. So we certainly think 50% at least in MS. Brain injury, tumours in the spinal cord or the brain, any of your inflammatory conditions, neuroinflammatory conditions, stroke, spina bifida, bleeds, same list. So again, this picture is to show that your bowel actually works well, unless you've got some other underlying problems with your bowel, a comorbidity, but it's the messages that are coming from your brain and your spinal cord, or one or the other, brain or spinal cord, that are interrupted. So the nerve innervation to your bowel is interrupted. So your bowel works fine or would work fine. It's the nerve supply that's causing the issue, hence the term neurogenic bowel. So this is again a reminder of our spinal cord and brain orientation. The brain is not on this picture, but I think we all know that it sits at the top of our spinal column. And this is to show the nomenclature of our spinal cord. So we start at C1 and we go all the way down. We've got the cervical, thoracic, lumbar and sacral regions to our spinal cord. And we can see that that spinal column, let's say, is made up of bone on the outside. Then you'll see the white space in the middle. That will have your cerebral spinal fluid, which cushions our spinal cord and our brain. That's going around our brain, and it's also giving energy and food to our spinal cord and brain. And then you've got that grey kind of S in the middle, which is our spinal cord itself, which again will be attached to our brain. And our brain and spinal cord are known as the central nervous system, okay? And then coming off of the spinal cord, you'll see at every level there, at C1, C2, C3, all the way down, you'll see that there is a nerve. There's actually two sets of nerves. This is a side profile. So at each level, the set of nerves that comes off supplies a particular part of our body. So if we're looking at the cervical region, that's a lot of those nerves there will go down our arm and our hands. And as you go down, it's different parts of the body. So these are your peripheral nerves. Okay, so that's different to your central nerves. The peripheral nerves only supply a certain part of the body. The central nervous system, the messages are coming the whole way down from our brain to us through our spinal cord. I like to think of our spinal cord a bit like a relay station that's sending messages back to the brain, and messages are coming from the brain out to the body. So you can see now, if you have got an interruption in those messages, you can see how it's going to affect the body. So this interruption here is just trying to depict, it could be a tumour, it could be an MS plaque, it could be a bit of inflammation or a bleed. That could be in your brain or it could be down your spinal column. But you can see now, if you had messages going up and down that need to get all the way down to T12, for example, you can see how those messages are going to be interrupted. Now, I point out T12, you can see it's a slightly darker grey line. If you take your eye down, around the T12 region, T12 to L2, is where your central nervous system changes to your peripheral nervous system. Okay, so around that region, on this image, it's actually sitting a bit lower. You'll see that there is a cone shape. You'll see that the spinal column turns into a cone shape. And then off of that cone shape, there's lots and lots of peripheral nerves. Okay, now that area is known as the conus. and that's where our central nervous system, our spinal cord, changes into this bunch of peripheral nerves. And that those peripheral nerves, you'll see it looks like a horse's tail. So that's what cauda equina means. Cauda, cord, tail, and equine for horse, equina. And this bunch of nerves are really, really important peripheral nerves. They're the peripheral nerves that supply our bladder, bowel, sexual function, and some sensation into our legs. So when we are talking about neurogenic bladder and bowel, it's pretty much split into two and a third mixed kind of area as well. So it's reflexive. You can have a reflexive or an areflexive bowel, okay? And then there's also, we'll talk about the mixed in a minute, but essentially anybody that has an injury, whether it's a brain or a spinal cord injury or, you know, MS, whatever, that is above your conus, above T12, that patient is going to be experiencing a reflexive bowel, okay? Anybody that has an injury around the conus region, which is different on all of us, our conus ends in a slightly different place for all of us, but it's around T12 to L2. This is where our central nerves are changing into peripheral nerves, so you can get a mixed pattern here. And then anybody who has an injury below the conus, or kind of around the conus and below, I should say, really, can experience a flaccid bowel, okay? So there is no reflex there, a flaccid bowel. So now we're going to look at the nerve innervation to our large intestines. So it's a little bit more complicated than the bladder in that you get some innervation from various different places, and you can see that there's a nerve supply here from the vagus nerve. We're going to ignore this part for now, and we're going to focus. Remember, we talked about the fact that if you have an injury around the conus area or below, you have a flaccid bowel. And then if you have an injury above the conus, so above the T12 region, you're going to get a spasmy, reflexy bowel. So why is that, I hear you ask? Well, if you look at, on this picture it's saying from T10, you can see if you follow these dotted lines, you can see it goes out into these blue nerves and then back round down to S1 to S5. So this is our reflex arc, and if you joined us the other week for the bladder one, we talked about the reflex arc around that area, and the reflex arc around this region is what causes our spasm, and it also allows our internal and external anal sphincters to contract and relax, okay? So you can see now, if you have an injury anywhere from T12 down, you are going to knock out that reflex arc. So this reflex arc basically works on its own, okay? This reflex arc can work without direct control of our brain. It can just be there spasming. But when it's under direct control of our brain, it works nicely, coordinated, in a nice coordinated fashion. If you have an injury on the conus, so T12 or below it, you can see here that you will knock out this reflex arc completely, okay? It just won't work. So what you end up with is anal sphincters that can stay open and relaxed. You no longer get that ability to spasm. Peristalsis is greatly reduced. You still get some because you can see with the bowel you have nerve innervation from other places, but it's greatly reduced, okay? If an injury higher up above the conus, Sorry, I seem to have lost my flashy thing to show an injury higher up, but let's pretend that there is an injury much higher up. Let's pretend it's up in the cervical region. You can see now that although the messages that are coming down that spinal cord and going up that spinal cord are going to be interrupted, and this is the same if there's an injury in the brain, the messages are going to be interrupted and confused, but the reflex arc is still present, okay? So what this is like, the reflex arc is now working on its own and it's not getting all of the information from the brain. So it almost, it's like, as I said on the previous bladder presentation, it's like the teenagers being at home on their own and there's no parents, there's no brain kind of guiding it to say, no, this is what you'll do when you'll do it. The teenagers are at home and they're partying. These spasms are going on, off, they're not coordinated. So you might have a spasm that you would need to pass stool, but your anal sphincter might stay closed, or your anal sphincter might open at the wrong time. So these patients, they do have peristalsis, but you know, it's just all discoordinated. Okay, so uncoordinated, so these patients can sometimes get accidents or they can't go to the toilet because of this. So let's move on to a reflexive bowel now. So what you find with a reflexive bowel is, as I said, that reflex arc is still intact, but it's working independently from the brain. Okay, so it's not in a nice coordinated fashion as if we were to go to the toilet, you would find an appropriate time, you would sit down and you would pass stool. Now, of course, we all know that there's a lot, passing stool is a little bit more complicated than passing urine in the fact that many of us have got, lots of people will only want to pass stool on their own toilet at home. Lots of people will know that there are certain things that they might eat or drink, like curry or coffee, for example, that helps us to go to the toilet. So passing stool is a little bit more complicated than just the pure anatomy and physiology of the nerves, and we just need to kind of be mindful of that as well. But going back to the reflexive bowel, what happens is you have an increased tone in your colon and your anus, and this then allows movement of feces along in a peristaltic motion, but it's not coordinated, the spasms aren't coordinated. And then there's impaired control over your anal sphincter, so you can see how that can cause accidents. There might be a loss of sensation or some loss of sensation, not always completely. So then we can see how patients can cause problems with their skin. If they're wiping themselves clean, or they're bearing down too much, you can see that could cause hemorrhoids, or wiping themselves clean, you can get skin problems because they're kind of doing it too roughly. The transit time can be increased because you get constipation or impaction, even worse, and you get incomplete emptying. Patients can feel bloated and they often get hemorrhoids because they're kind of forcing themselves to go to the toilet. Straining rather, not forcing, sorry. So what can we do about this? Well, so I think a lot of bowel management is really starting from the basics as well. Let's not forget, yes, they have a neurogenic bowel, but let's just remember our basics as well. Okay, so educate on the importance of diet and exercise. Exercise is great for all of our bowels because it just allows peristalsis to go on. It just allows for a nice movement through our gut. Think about our diets. We need to talk to our patients about diet, about fibre, about enough fluid. You can see already if a neurogenic patient has got bowel issues, they're very, very, very likely to have bladder issues as well. They just come hand in hand. So if you think about someone who's got bladder problems, we know that they often want to dehydrate themselves because they don't want to keep going to the toilet for a pee. We know that that's wrong, and you can see how that is going to just feed into more constipation. We can see how constipation causes UTIs. These bladder patients already get UTIs, so you really have to think of it as a kind of all-encompassing entity. So we need to be doing our basic education on diet and exercise. Now, you might think straight away, oh, tell them to have loads and loads and loads of fibre, but actually for some of the patients you need to monitor that and you need to start tailing it back, because some of them are too loose and some of them are too constipated. So with this group you're probably aiming for a Bristol stool of around 4 to 5. You don't want them too hard and you don't want them too soft. So what I always recommend, and this is adapted from the MASKIP guidelines, you can go there if you want kind of more detail on all of this, but you need, I usually recommend to patients that they try and get into a good daily morning routine, okay, because your gastrocolic reflex is at its strongest in the morning. And also, if you have a patient that our patients are in hospital or with you in your outpatient clinic for a very small period of time, they want to, obviously, we want them to go out and live their lives, work, meet their friends, go to school, whatever it might be. So at least if they empty their bowels in the morning, then they will know. For some people it might be that they're good for the rest of the day and they're not going to be worried about having accidents or having cramps. For some people it might only be 4 hours, but at least they know then, look, I've done this, I've got this amount of time to do the shopping or to collect the kids, whatever. However, if a patient really doesn't want to do the morning and they say, mornings are just too chaotic, I've got to get 3 children to school, blah, 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 you know, we have to be realistic. Bowel routines can take, 40 minutes, maybe even a bit longer. So if they don't have the time, don't work against them, work with them. So sometimes I will say, look, do it in the evening if you feel that that works better for you. But I always try morning first. I tend to start patients on Senna at night, Movicol in the morning with glycerin suppositories. That's what I always start with. And for some patients that will be too much, but I always like to start from there because then you know at least that you've cleared them out, and then you can start tailoring things back. Then in the morning, you want to also, they have their Movicol and their glycerin suppositories, breakfast and a hot drink. The hot drink's really important because again, that stimulates your gastrocolic reflex. So what you put in, it often stimulates your gut, and then we want to go to the toilet. And I'm sure lots of you will that will resonate with lots of people. You have a coffee in the morning, it makes you want to go and have a poo, or Weetabix in the morning. Talking about Weetabix, I tend to ask patients to try to have porridge. Loads of people, porridge seems to really work for them to help them have their bowels open. Weetabix. Another thing that I tend to ask patients to do is get linseeds or flax seeds and put it on their breakfast. That have lots of anecdotal evidence from patients to say that that really helps them. And the hot drink can be anything. It doesn't have to be tea or coffee. And then I encourage them to do abdominal massage. So you can just Google that and there's loads and loads of videos, but essentially you follow the lie of the gut. I get the patients to use the palm of their hand, tell them to use a bit like kneading dough, so not too soft, not too hard. You don't want them to hurt themselves, but they do need to get down to their gut. They're basically doing the peristalsis manually, let's say, and you follow the lie of the gut. So start at the bottom right hand corner, massage up, across and down. And I get patients to lie down on their back, and if they're quite slight, they can often feel, they'll get used to it, and you can feel if there's a blockage. It's often around here. I'm sure that won't surprise any of you. The other thing that I find really helps is hot. So hot drinking, but also actually getting them to put a shower on their tummy, or like a warm pack, or getting in the bath. That often helps. And I'm sure many of you with children, young children, you'll remember that when you were potty training, when you put them in the bath, often they would open their bowels. Which isn't a pretty sight, but anyway. The other thing that I tend to ask patients to do is invest in a squatty potty. So these are, again, if you get onto Google, you can find them for £10 up to nice swanky wooden ones that are designer, but it's just basically a stool that allows you to put your feet on when you're going to the toilet. We should all actually be in more of a squatting position, so your knees should be higher up than our usual toilets allow us to do. And then I tell them to pop along to the toilet. So even if they're saying, oh, they only go to the toilet kind of twice a week or 3 times a week, I try to get them to follow this every single day. Okay, now if all of these things aren't working, then you would talk to your patient about doing some digital stimulation. So what I get the patients to do is sit on the toilet, and actually if they have got a reflex, if it's a reflexive bowel, just by touching around their anus can often cause it to spasm. So they can try that. If that doesn't work and they need to manually remove feces, that is digital removal of feces with a finger, then I would always offer patients a choice of either doing that or a transanal irrigation kit like Peristeen Plus. And what we know is that patients that are using Peristeen Plus, that often eliminates, if they do need to use that, if they do need to manually evacuate, using Peristeen Plus instead of using a finger often eliminates the need for all of their laxatives or some of their laxatives at least, and we know that it tends to clear their bowels much higher up than a finger can. So for patients who are having to go to the toilet 3 or 4 times a day, then you really might want to be thinking about Peristeen Plus, because it might just be that it allows them longer times to not be on the toilet. So just a little, if any of you don't know what our transanal irrigation kit looks like, this is Peristeen Plus. It's just been upgraded recently, and it's the only NICE approved transanal irrigation kit out on the market. You can see that blue dot there on the bag, that's just about to come out. That is to show the temperature of the water. So as we talked about, hot helps with our gut. We don't want this water too hot in Peristeen. We don't want it too cold either, because that will cause cramps. You want it at a nice kind of body temperature actually, and the temperature dot there will tell the patients when it's at the right temperature. The new kit that you see here has been redesigned with neurogenic patients in mind, so the dial is much easier to use, it's easier to hold, and the connectors are much easier to put together. So this is just a very quick image to show you how high up the water goes. Sorry, I should have said actually, so if I just go back, just for you, those of you who don't know, you fill this with water and then essentially you irrigate your bowel, and you can see here, this picture just shows that the water does get quite high, quite far up, and just nicely allows the stool that's in your large intestines to be removed. And I just wanted to show you this. If you look at the left hand side, this is a neurogenic patient. This is, the left hand side is somebody's gut that has that hasn't passed stool, and then you see underneath it somebody who has passed stool. If you move into the middle, you'll see a spinal cord injured patient who, the top, they have not passed stool, and then underneath you'll see this is after digitally, so manual evacuation with your finger. But then if you see my arrow here, this is the results that you get with transanal irrigation. So you can see it really does clear out a lot more of your colon. So we're going to move on to flaccid bowel now. Okay, so this is the flaccid, floppy, the bowel that has lost a lot of its peristalsis, and the bowel where your anal sphincter is often open. So as it says here, reflex arc is not intact, and therefore you lose some, all of your peristalsis, you lose tone in your anal sphincter as well. You can see how stool propulsion through the gut is going to be really, really, really slow. These are the patients that really can get impacted. They can have nil or impaired sensation. They can be fecally incontinent, because if you imagine if your anal sphincter, your external sphincter is open, what happens is typically these patients can often get really, really constipated, impacted, and then the liquid part of the stool bypasses a big impacted area, and patients think, and clinicians also think, that the patient has got diarrhea. Of course, it's not diarrhea, it's impaction, but the whole thing gets worse because their laxatives are stopped, and we're just making the situation worse. So always think with these patients, if you think they've got diarrhea, really think, is it diarrhea? It's, unless, you know, they've been near somebody who's infected, it's very likely that they're actually experiencing overflow, okay? So high risk of impaction, high risk of bloating. Lots of patients will say they really, really feel bloated with these bowels, and they just never ever feel, they'll say they'll just never feel like I've fully emptied. And they high risk of hemorrhoids because they're bearing down, and they just can't get that stool out. So what is the management for these patients? Well, again, it's just the same as the reflexive bowel. So lots of these patients, by the way, will be your cauda equinus. A lot of them will get a flaccid bowel. So educate the importance of diet and exercise. Again, being up, being mobile, really, really important. The daily routine, again, in the morning, super important. Just the same as what we spoke about for a reflexive bowel, Senecot at night, Movicol in the morning. The only thing that changes here is the fact that we don't use suppositories. Why don't we use suppositories? Well, it's not going to harm them. So if you're ever in doubt, use the suppositories. What's going to happen is they're just going to fall out, because remember, they don't have that tone. And actually, glycerin suppositories are just there to irritate and to cause your bowel to spasm. It's sugar, and it shouldn't be there essentially, so it causes it to spasm. So because you lose the ability to do this, they'll just fall out. They won't, and they won't create that spasm because you've lost the ability to do it, because you've knocked out the reflex arc that creates the spasm. So you'll soon find out, because these are the patients, you go back to them and the suppositories on the bed or in their pad. So you want to have breakfast with a hot drink again. Remember, we talked about the porridge, we talked about Weetabix, linseeds, flax seeds. And these patients, they are not going to be able to pass feces. They need to manually evacuate, full stop. If they've lost the ability for peristalsis, or it's really, really diminished, they need manual evacuation. So again, as I said, any patient that I had that needed manual evacuation, I would also offer Peristeen or, you know, transanal irrigation. So again, really, really good results with this. Many of our patients will say that they just feel so much more clear. It gives them more time during the day. They don't have to keep going to the toilet or having accidents. We already looked at the Peristeen Plus system, but the other thing that I wanted to draw your mind to were anal plugs to prevent soiling, and you can just see a picture of one here over on the right. And again, if you have any patients that you think this might be suitable for, we do make anal plugs. And for any of you that don't know what they are, it looks like a tampon basically. So if you look at the small picture in the top of this image on the right hand side, it looks like a tampon. It's got a string, which is a kind of a bigger string than a tampon string, and you pop it in to your bottom, and then what happens is it's got this kind of it's not plastic, it is something that just degrades with the heat, and then it opens up into this cup shape. So it sits there nicely and it just catches any leakage that was going to happen. Now these are really good on a flaccid bowel because remember they've lost that ability to spasm. However, if you use these on a reflexive bowel patient, remember I said to you, if you touch around your rectum area, your anus, that can cause a spasm. So for reflexive patients, these can often create uncomfort and spasms. So you can try them. Certainly some people get on with them, but just be mindful of that. If with a reflexive bowel, these sometimes just create a little bit of irritation, but it's certainly worth trying. So this is just a quick, when do we consider transanal irrigation? Well, we always start with education on diet, lifestyle, well-being. We would then always move on to laxatives and suppositories, and then transanal irrigation will come next. So like I say, for any patient that I would have to suggest manual evacuation on, that's when I start to think about Peristeen. And then obviously, if that's not working, there's various other things, but at that point you really should be absolutely referring on to a very specialist unit. So I just wanted to give you a couple of examples of where we can help, because for some of you, you might be thinking to yourselves, oh, this is all great, but I don't really have the confidence to sort of do this on my own, or I don't really know what I should be asking these patients. So there's a couple of different examples now of toolkits. Now this is the mental tool, which Anton Emmanuel devised with some other global clinicians. And this currently has been audited and verified to use with spinal cord injury patients. However, Anton and the authors do say that they feel it's a safe tool to use on all neurogenic patients, but they're in the process of validating that at the moment. So it's validated for spinal cord injury. If you were to use it on other neurogenic patients, that would be a clinical decision on your part. And I would also recommend that you perhaps get the paper and take a look at what the authors say. So the things that are on this, the mental tool essentially gives you a number at the end. It helps you, it guides you in understanding whether your patient's bowels are managed well, managed sort of okay, or not being managed at all. And then it allows you to kind of think about changing what you're doing with them. Okay, but I just like it because it makes you think about questions that you might want to ask your patient, and it might help you if you're not someone who's really used to dealing with neurogenic bladder and bowel. Think about the things that we might want to be asking them. So I've just made a little list here because it's difficult to see the actual form, but you know, you're looking at frequency of bowel emptying, time spent on the toilet, what medications are they taking for constipation or for loose stool? Are they using their finger to stimulate? Are they using their finger to manually evacuate? How many accidents are they having? Are they passing wind involuntary? Are they satisfied with their bowels or not? Is it taking over their life? And if patients are coming and sort of scoring on these things and they're not feeling satisfied, then it just alerts you as a clinician to go, okay, are we actually really managing these bowels properly? Can I do anything to change it? Or should I be, do I feel comfortable to change it or confident, or should I be referring on? This is just a quick example I want to show you. This is something that when I was at the National Hospital for Neurology and Neurosurgery at UCLH, I devised, and it was just an acute spinal injury bowel management plus brain pathway that just allows clinicians who are not specialists in the area to really quickly look and go, okay, so I'm following a reflexive routine and this is what it is, or I'm following a flaccid routine and this is what it is, or actually this is a mixed picture, and just alerting people to what they should be doing, and if they were not comfortable to prescribe this themselves, then they could reach out to us as a specialist nurses there. And it's just really to say that if this is something, if a pathway like this, or if you're feeling like a form like this might help your service that you work in, please do reach out to us, because we're really happy to help devise these with you and give you some advice on it. I just wanted to finish up really with another report by Anton. Anton seems to be the man doing everything really in neurogenic bowel, and Ben Disney. So Ben Disney is a consultant, gastro consultant in Coventry, and Professor Anton Emmanuel is a neurogastrologist who works at the National Hospital in London and also at Stanmore, and he now works with NHS England as well. So these two basically did a report, which is it's actually not July, it's September. That's a typo, sorry. It came out in September with the Bowel Interest Group, and it was essentially saying that healthcare professionals need to give adequate support to patients when they first set off on a new treatment plan. So that might be, you know, upping their suppositories, or it might be Peristeen, for example. And if you don't give these patients regular follow-ups and regular touch points to tweak the treatment, then many of them will just not adhere anymore. They'll just fall off of the treatment plan. And it also, the report shouted out that healthcare professionals should be giving patients all the information accessible and giving them the choices. So you could either follow this treatment plan or you could follow this one, but we need to be giving our patients all the choices that are out there. The full information and the benefits of the different choices and the adverse effects should also be called out to the patients, and they should be given alternative choices as well. And we should, as clinicians, be explaining the rationale and the treatment, because if you don't explain to somebody why they need to follow a certain routine, then they're just not going to. And we should also set expectations. So, for example, if you were to start somebody on Peristeen, for example, you know, I would never say to them, oh, use this and everything's going to be great in a week's time. We need to say there's a bit of tweaking, as with any bowel routine. There's a bit of tweaking, and we set the expectation. You need to stick with this plan for 6 weeks, and then, you know, we'll tweak in between. But what it also points out really in those early days, those early couple of weeks, they really need to have a couple of touch points from their healthcare professional. And we know that that is not particularly realistic all the time in busy units. You might be thinking, well, there's no way on earth I can have all my patients back every week or so. And again, that's somewhere that we can help. If you're thinking of any of your patients now that you think, oh, actually Peristeen might be a really good option for them, then Jo Booth is your local Peristeen advisor, and she can give you, she's a qualified nurse of many years, and she is a fountain of all knowledge and will support those patients in the early stages. And then also we've got our charter service, so the patients can call up if they've got any problems, and they are all highly trained telehealth, kind of almost like healthcare healthcare assistants, and then they will pass information on to the nurses as they need to. And I just want to also say congratulations to all of our nursing team who are who achieved, or well, we achieved an outstanding CQC. So you can rest assured, if you do want some support from us, that our nursing service has got outstanding CQC, which is something that we are super proud of, as I'm sure you can all appreciate. So thank you for listening. I hope you've learned something, and as I say, if anyone wants any more information on anything, whether that's Peristeen itself, whether you're thinking you've got a patient that might help with, whether you're thinking on pathways for bowel, and that's general pathways, not just transanal irrigation, we start from the beginning the whole way up, please do reach out to Jo. I've popped her details up there, and she will then be in contact with me, or as appropriate, whoever else. Thank you.
Thank you, Michelle, for a really informative talk, and I hope people found it really worthwhile, especially as a sort of carry on to the neurogenic bladder management training that we did a couple of weeks back. Before I ask a question, just to remind people, feel free to put into the Q&A box any questions for either Michelle or Joanne, who's here with us today. Equally, as a reminder, the network are organising a task and finish group that will look to run in the beginning of the new year. So if anybody who's watching this today does want to be a part of that task and finish group across Greater Manchester, then do get in touch with either myself or any of the team here today, and we'll make sure that we include you in that. And obviously that is looking at reducing the variation across Greater Manchester and looking at those pathways and assessment tools, etc. Just a quick one, and I'm sure this is fine, guys. Just in terms of the neurogenic bowel scoring, are we fine if you share the link with us and we can include that in with the email that goes afterwards with the link? Is that okay?
Yeah, absolutely. Yes, yeah, we'll forward that to you. Yes.
Perfect, and then everybody's got access to it. So clinical question here. When would you use Docusate?
Do you want to take Michelle? When
would I use Docusate? Yeah, I mean, I think we can both tackle that one together, Jo. So I personally tend to always start with the neurogenic patients. As I said in the video, I tend to always go with Senna at night as a nice slow acting, so that if you're going, well, I caveat that I don't always start with Senna at night. If I'm going for a morning bowel routine, I'll always start with Senna at night. If you're going for the evening, then switch everything around. Then I'll move on to Movicol in the morning. If it is a reflexive bowel, then suppositories as well. I start with that just so that's quite, you know, it's obviously quite I find Movicol works quite well and it's quite strong. Because I want to be sure that I've cleared these patients out. And then if you are doing manual evacuations or using a transanal irrigation kit, do that also. I want to make sure, me personally, that the patient doesn't have diarrhea, that they're actually impacted, if you know what I mean, which is usually the case. So I start strong until I am really comfortable that they are completely cleared out. Especially if you're not using a transanal irrigation kit, then you know you kind of have to be really certain that you have cleared these patients from high up. Then I will start to rejig, and if you then tend to find that their Bristol stool is really too loose and you're comfortable now that actually they're just on too much medication, then I start to draw back and I might swap them around and start to switch and see, maybe remove the Movicol. I tend to keep the Senna, just one at night, and then I might add in a Docusate instead, start with 1 or 2, you know, it is a kind of playing around really. I also talk to my patients because lots of them will be used to taking things for ages and will say, oh, actually, this really works for me, this doesn't work for me. Jo, I don't know if you've got anything to add?
No, I would say similarly. I mean, I'm not a prescriber, but again, it's essentially, obviously, when you want to make sure that bowel is clear. So I think titrating Movicol in combination with a stimulant laxative is usually the way to go. And then again, it's tailing it back. And not everybody can tolerate a Macrogol, in which case then sodium Docusate would be a good choice of softener.
Yes, absolutely, agree.
Thank you both. And then, Jo, this one directed at you. I think it was just a little bit more of an explanation around your role and how you can support teams, sort of either in the community or in hospital.
Yeah, so the Peristeen team, we're a national team. We're all registered nurses, so we do cover the country nationally. Our role is very flexible, and we will really do what it takes to support the patient and those associated in supporting that patient with their care. So we're quite happy to provide training to any community teams, anybody really involved you know, in supporting that patient. And we tend to arrange, if a patient is already in the community, we'll provide that training in combination with, we would recommend a supervised irrigation to begin with. So we'll do that training, make sure that either the patient or those associated in their care are comfortable and feel competent in putting the parts together, and we'll also sort of be with you sort of to supervise that sort of first irrigation, so that we can be there to sort of answer any questions and do any sort of troubleshooting.
Thanks, Jo. So I think that's it for questions that we've got thus far. I'll just give people a couple of minutes and just ask very nicely if people would mind rating today's session just in the Q&A box. I think I've put a little announcement in there, but if you just rate it 0 to 5, 0 being poor, 5 being excellent, hopefully you found it excellent, and then with a brief comment just kind of what you thought, anything for future training, etc. It just helps direct any training that we do going forwards. I just want to add as well that obviously we are delivering these online at the moment because of COVID, and I know previously we have run face-to-face training with Coloplast that have delivered more kind of hands-on practical training. As Jo said, she's happy to go out to teams and to provide that training, but hopefully in the new year we'll be looking to see if we can deliver something on a GM level around practical training, but obviously it does depend on what kind of how the pandemic kind of continues and persists, really. So it might be, if you are looking for something sort of imminently within your teams, then doing something on a local level might be the preferred option currently. That's great. So Jo, Michelle, don't know if you've got anything else you want to add, but other than that, I think we've taken the questions for today. So thank you for your time, really appreciate it, and hopefully we'll catch up again soon and deliver something face-to-face, fingers crossed.
Yeah, that would be great. Yeah, thank you for the opportunity. And so it's always great, you know, we try our best with webinars, but face-to-face is always great in terms of getting the conversation going. So we look forward to those times.
Absolutely.
Brilliant. Thank you all. Thanks now.
Okay.
Thank you. Bye.